Okay, dear colleagues, this is a second webinar in 2022 from the EANS Vascular section. I'm very happy that Aki Laxo is with us. It's the first time in these vascular webinars that we're covering the topic of AVMs. And it's not so easy to find an expert for AVMs, but now we have a true expert. I know Aki since a longer time from the EANS courses, and he always gave brilliant talks about AVM surgery. So I think he's the right guy for informing us about the brain AVMs, the natural history, and the quality of life. Aki is coming from Helsinki. And we have now roughly 45 minutes for his talk, and afterwards it's possible to ask questions, but be aware that the questions should be done via chat. So put the question, if you have a question, put it in the chat, and afterwards, at the end of the talk of Aki, we will answer all the questions. Well, Aki, I'm quite happy that we meet virtually at least, and that I can hear you talk now. The stage is yours. Aki, please.
Thank you. Thank you, Veit. It's a pleasure. And the topic is pretty familiar for me. I've given this talk or similar talk about AVMs and natural history quite many times over the years. Hopefully this is at least to some of you, this will be somehow new, even though the data is actually not so fresh, because the natural history studies pretty much have been done, and I don't believe that there will be groundbreaking new natural history studies coming, and most of the natural history series are based on older historic cohorts for pretty obvious reasons. The quality of life data, on the other hand, is much more recent and hopefully new even for many of those who may have heard the natural history talk before. But anyway, I will start with the natural history part. And what we mean about natural history, we of course mean that what happens to a lesion or a disease if we let it run its natural course without intervening any way. Part of the natural history, of course, is presentation. And nowadays in industrialized countries, new AVMs are diagnosed with an incidence of approximately 1 new case per year per 100,000 persons. The prevalence, meaning that, you know, how many of us are carrying an AVM throughout our lives, is much more difficult to know and study, because these are rather rare lesions. The prevalence may be up to 0.2%, and this figure is based on a German study where they did an MRI to approximately 2,500 young, healthy German males who were applying to German Air Force. And the brain MRI scan was part of the recruiting process. And they actually found a previously undiagnosed AVM in about 0.2% of these young fellows. Nowadays, there's more data suggesting that at least not AVMs are congenital, but they actually they may develop later in life. So even the prevalence number may not be static, but anyway, it's rather low. The presentation, I mean, they may present at any age, but on average, the typical age of presentation is around between 20 to 40 years, but they may be found even in young infants, or they may be found in elderly people as well. Still nowadays, the most common type of presentation is hemorrhage. Nowadays, approximately half of the cases are diagnosed because of a new hemorrhage. but of course, with the availability of non-invasive imaging becoming more and more common, we also find more and more unruptured AVMs. About a third of the cases are diagnosed because of epilepsy, maybe roughly 10% because of severe migraine type headaches, and let's say less than 10% because of progressive neurological deficit that is not related to bleeding. The number of incidental AVMs obviously is increasing because people get imaged because of rather mild symptoms, and not, of course, not all diagnosed AVMs are symptomatic in any way. These are in some ways most difficult cases to handle, because then you really probably should be quite conservative about them. Of course, because the hemorrhage is still the most severe type of symptom that AVMs may cause, the risk of hemorrhage has traditionally been of great interest. And pretty much the only way to estimate the risk of hemorrhage is to follow up patients with known AVMs without touching the AVM for several years and seeing what happens. And these are the natural history cohorts in which the statistical analysis of the hemorrhage risk have been conducted properly. The latest one has been the so-called MARS study, which was published by Helen Kim and colleagues in 2014, and it's based on in a multi-center cohort analysis. And Kim and colleagues, including us, are doing kind of a follow-up for MARS called MARS-2 study, which concentrates on unruptured AVMs, but that actually includes also treated patients. So honestly, I doubt that we will see a large unbiased natural history cohort anymore, because most cases where especially the ruptured cases will be treated nowadays. For unruptured, it's a different story, as you all probably know, especially after Aruba. I will concentrate now on our own Helsinki series that was published almost 15 years ago already. And the reason being, of course, I mean, that's the cohort I know best, but also because it's still the one with the longest treatment-free follow-up period of all these cohorts, and because the hemorrhage risk doesn't seem to be stable over time, I do believe that you really need sufficiently long follow-up to estimate the hemorrhage risk. You cannot substitute the long per patient follow-up time with collecting thousands of cases and then following them up only for a short period of time. I don't believe it's the same thing or a good substitute for a sufficiently long follow-up time. Anyway, in our paper, we had 238 patients with untreated AVMs, and Helsinki was the only center who diagnosed and treated AVM patients in Finland for several decades. So the first patient was diagnosed already in 1942, and the last patient in this cohort was diagnosed in 2005. The mean treatment-free follow-up time was 13.5 years. The follow-up ended if the patient experienced a rupture or a new rupture during follow-up, or the AVM was treated, or the patient died for any reason, or if he or she was lost to follow-up. But we didn't really lost any patients to follow-up. The follow-up was complete for like 98.7% of the cases. We observed 77 hemorrhages during the follow-up, or the hemorrhage in 77 cases during this time, and this very simple calculation gives us the average rupture risk of 2.4% per year in all cases combined, and you can also see the Kaplan-Meier curve of the whole cohort without any stratification by any characteristic factors of the AVMs. Then, of course, we looked at several different risk factors for rupture, and previous rupture has been, of course, well recognized to be a risk factor for a subsequent rupture, and it was also a very significant risk factor also in our series. So during the first 5 years, the annual rupture rate was over 6% in those cases who presented with rupture, and a little bit over 2% in those patients in whom the AVM was diagnosed unruptured state. But if you look at the whole follow-up period, you can see that actually the rupture risk starts to get lower over time after diagnosis, both in ruptured cases and also in unruptured cases, being the highest for the first 5 years after diagnosis. The reason for this is unknown, probably because most of these cases were symptomatic anyway. Even in cases of unruptured AVMs, there's probably something happening in the AVM somehow and stabilizing it, which may increase the risk of rupture during the first 5 years. And then, you know, if everything goes fine for a few years, the risk gets lower. And actually, if you look at the rate of rupture in our unruptured cases for the first 5 years, 2.3%, it's quite nice that Aruba study that you all know, which is basically a prospective follow-up of unruptured AVM cases, in the conservative treatment arm of Aruba, for the first 5 years, the rupture risk was 2.6%, almost identical to our series. And in my mind, this is actually the nicest thing about Aruba. It's a prospective confirmation of our retrospective epidemiological data. And I think it's a pretty nice validation for our cohort data that has been sometimes criticized for, you know, being retrospective and old and biased and whatever. So so I think this number is actually a pretty solid one, about 2.5% for the first 5 years for unruptured cases. Size of the AVM is a little bit complicated issue. I know that many of you may have heard the idea that small AVMs are more prone to rupture than large ones. There's actually no good evidence for that. What is very true is that when you look at the AVMs at the time of presentation, small AVMs are much more likely to present with rupture than large AVMs. But that's of course because the large AVMs are more likely to cause also other symptoms like epilepsy or focal progressive focal deficits, because they may cause, you know, they have mass effect, more irritation in the surrounding cortex and so forth. But if you actually follow up the untreated AVMs, the small AVMs are definitely not more prone to rupture during follow-up than large one. Actually, quite the contrary. If you look at now this univariate Kaplan-Meier curve, there's no significant difference. But if you look at the blue line, which are the large ones, you can see that there's actually a trend for higher hemorrhage rate. And we come back to this when we look at the multivariate analysis of our cohort. And there, because there's some surprise. Superficial versus deep location, superficial meaning basically cortical AVMs, and deep ones, those in, you know, basal ganglia, interventricular, brainstem, and so forth. The deep lesions are much more prone to hemorrhage than superficial ones. Of course, this is still univariate analysis, and the deep ones also are more likely to be ruptured when diagnosed. So, there's a confounding factor, but we come back to this also in the multivariate analysis. The same thing holds true for supra versus infratentorial AVMs. Infratentorial AVMs are much more likely to bleed or rebleed than supratentorial ones. But again, most infratentorial ones in this cohort were ruptured already when diagnosed. So there's additional risk factor from that. Venous drainage pattern was a bit complicated as well. Especially if you look at the longer follow-up times, I have no explanation why the curves behave like that. But let's say that during the first 10-20 years, the pattern was quite clear and even statistically significant for the first 5 years, in a sense that those AVMs with purely deep venous drainage were much more likely to bleed during follow-up. Of course, they also were more likely to be located in deep locations. And those AVMs with both cortical and deep venous drainage were least likely to rupture early during follow-up. This might mean that that those AVMs with multiple draining veins are less likely to bleed, which hemodynamically actually make quite a lot of sense, because at least in some cases the reason for bleeding probably is restriction of venous outflow for some reason. This table shows the cumulative rupture rates based on survival tables from our cohorts for first 5 years and then for first 20 years with 95% confidence intervals. This, of course, is again like a univariate stratification. So for any ruptured AVMs, the risk of having a rebleeding for the first 5 years is about 26%. For next 20 years, it's about 45%. And if you look at, for example, the infratentorial AVMs, for any infratentorial AVM from our cohort, the probability of having a rupture during the next 20 years is over 75%. So even though this is a univariate table, this actually is pretty handy for patient counseling, but of course it doesn't take into account of multiple factors that may play in opposite directions. These are now I have a little bit a problem of seeing my own slide because of the Zoom, which occludes my title. Yes. So these are the independent risk factors based on a Cox multivariate model. So we put all these risk factors, and of course along with sex and age, into a Cox model to see what risk factors become independent risk factors even after taking into account the confounding variables. And this is probably the most important slide in this natural history part of my talk. So the previous rupture is, of course, a very robust risk factor with over twofold relative risk compared to unruptured AVMs. Deep location and infratentorial location remained independent risk factors for subsequent rupture, despite the fact that they often associate with hemorrhagic presentation as well. Of course, there may be statistical bias and it's impossible to like completely reliably dissect the effect of original rupture and deep or infratentorial location out of it, but at least in this cohort and in this statistical model, they seem to be significant independent risk factors as well. And here we come again to the large size. So even though in the univariate model, the size was not statistically significant explaining factor for new risk, you remember how that Kaplan-Meier curve for large AVMs looked like they would have higher risk, and in this model, the large size actually is an independent risk factor for bleeding during follow-up, with over 3-fold relative risk compared to small AVMs less than 2.5 centimeters in diameter, and the medium-sized AVMs going in the middle. And the reason why this comes up statistically significant only in the multivariate model probably is because of the statistical interaction between the size and hemorrhagic presentation. As I told, it's true that small AVMs are much more likely to present with hemorrhage, because if they don't bleed, you don't even diagnose them. The patient doesn't know that, or the person doesn't know that they have an AVM, and we don't know. So hemorrhagic presentation is kind of overrepresented in those patients who have small AVMs. And that's why you don't see it if you look at only size in univariate model. But when you put it in the multivariate model together with the previous rupture, you can actually see that large AVMs, in fact, are more likely to bleed during follow-up. So please forget the old mantra saying that small AVMs are more likely to bleed. There is no evidence for that, even though they are more likely to first be diagnosed with bleeding. And then one reminder about these, this risk prognosticating over time. Please remember that if you memorize something that, for example, that all AVMs on average have about 2.5% annual risk of rupture, and if the patient asks, well, how what's my risk over the next 20 years, it's not a simple multiplication, because if you have an annual risk, it's a logarithmic function, and even with annual risk of 2%, it doesn't mean that in 50 years the risk is 100%. It never actually reaches 100%. But this formula would hold true only if the risk would be constant over time, and at least in our cohort, it looks like it's not even constant. So really the longer term prognosis should be estimated on actual cumulative life table data, not on simple arithmetical calculation. We also looked at long-term mortality, and this is a cumulative relative survival ratio of untreated AVM cases observed over a period of 30 years. And this figure, this is not a simple Kaplan-Meier survival curve. This means that the cumulative survival of the cohort is compared to general population of same age, same sex, same historical era. So in a way, like it's okay if the patients in this cohort die, if they die at the same rate as the background population. If they die at the same rate as the background population, the cumulative relative survival ratio would remain at 1 over the 30 years. If this starts to drop, it means that there's excess mortality in the cohort compared to the background population where they live in. And in our case, the background population is the whole population of Finland who lived here at the same time as the patient. And this curve means that because the cumulative relative survival ratio drops to 50% over 30 years, it basically means that this cohort has twofold excess mortality compared to general population of Finland. And if we look at the AVM cases in whom the AVM was completely eradicated from the same period of time from Helsinki University Hospital, you can see that the cumulative survival is almost the same as in the background population. It only drops about 10% over 30 years, meaning that untreated AVMs are associated with significant excess mortality that seemingly can be almost completely reversed by treating the AVM. Not completely, of course, because there's also mortality associated with AVM treatment, but still it reaches almost no, the treated cohort reaches almost normal survival. Okay, that's about natural history, and then we look at the quality of life data. That's a little bit more recent, of course, based partially on the same cohort, and the two papers that we have published about this were actually part of the PhD thesis project of my pupil Anni Pohjola, who is now a young resident. And the first paper we published about 3 years ago in neurology, and that was the first quality of life analysis we did from our cohort. And the way this was done was that in 2016 we contacted all the AVM patients in our cohort who were adults and alive in 2016. We sent them a bunch of, a letter, cover letter, and bunch of forms to fulfill, including the quality of life questionnaire that I present more closely in a while. And from that cohort, we selected 262 patients in whom the AVM was completely occluded before the survey. So untreated patients were not part of this study. You can see that because it's a large cohort and spans several decades, you can see that the mean age on admission when the AVM was diagnosed and subsequently treated was about 35 years, but the age at reply was a little bit over 50 years. So actually survey was done for many cases, perhaps decades after the diagnosis. But this was the only way to collect significant number of cases for such a rare disease. In majority of the cases, the AVM is ruptured at least once. Then there were, maybe a third of patients had an originally unruptured AVM, and then there were about 25 cases with multiple bleeding episodes before the AVM was treated. We looked at Spezza-Pons class. You know what it means. Spezza-Pons A means Spezza-Martin grades 1 and 2. Spezza-Pons B means Spezza-Martin grade 3, and Spezza-Pons C is Spezza-Martin grade 4 and 5, just to make it statistically a little bit more easier to handle with only 3 groups. And as you can see, in vast majority of cases, surgery was at least part of the treatment, but in many cases the treatment was multimodal. And the quality of life instrument that we used was this 15D questionnaire, and the reason we chose this was that this was developed by a Finnish epidemiologist, Harri Sintonen, which means that this has been extremely well studied and validated in Finnish population and in multiple disease cohorts before. Plus, we could have Harri as a collaborator with us, which was tremendous help, of course, for the statistical analysis. This is a little bit more extensive than the widely used EQ 5D score. It has 15 different dimensions that are rated individually, and in addition, a mean 15D score can be calculated, in which the different dimensions are weighted according to estimated importance for the total quality of life. And the mean 15D score gets a value from between, it's a continuous value between 0 and 1. 0 meaning that you're dead, and 1 means that you're in perfect health and function perfectly without any problems in any of these areas that the dimensions ask about. And another thing about quality of life science, to those of you who are not very familiar with it, the health-related quality of life is much more complex issue than just asking a person that, you know, how happy you are or how satisfied you are with your life. The patient actually, or a person actually, may be quite happy, but he or she may still have significant problems with movement, vision, hearing, and so forth. So asking about all these things in a structured way is much more objective measure of quality of life than very simple happiness-related questions, and also more informative and useful for healthcare professionals, of course. So on with the results. First of all, if we look at the whole 262 patient cohort, and we compared them to our age and sex matched general population comparison cohort that had over 1,300 participants, and not so surprisingly, we can see that the mean 15D score, like the total quality of life score in the patients, is statistically significantly lower than the general population. That is, of course, I mean, the general population doesn't mean necessarily healthy population. It just means like a random sample of age and sex matched Finns. If you look at the mean 15D score, about 0.93 in general population compared to 0.88 in patients, this is clinically significant drop in the quality of life. Something like around 0.1, 0.15 difference in mean 15D score already is considered in practice like a clinically significant change in the quality of life. There were also several individual dimensions in which the patients differed from the general population: movement, vision, eating, speech, usual activities, mental health issues, depression, and so forth. Then if we look at some AVM characteristics and disease specific characteristics, this is the SPECT/PONS classification, and not surprisingly, the patients with the SPECT/PONS A type AVM, meaning spectrum grade 1 and 2, had best quality of life after treatment, and SPECT/PONS C, meaning spectrum grade 4 and 5 AVMs, had the lowest. This is of course expected. What is actually interesting about this is that the SPECT/PONS A and B actually didn't really significantly differ from each other, meaning that SPECT/PONS B class AVMs probably, especially with some care in patient selection, probably benefit from treatment as well as the SPECT/PONS A AVM patients. Number of bleeding episodes, again, not so surprising, but important to note is that the patients with unruptured AVMs who were treated had the best quality of life after treatment. Those with multiple bleeding episodes had the worst, and those with just a single bleeding episodes were in the middle. Epilepsy was actually very significant factor affecting the quality of life of the patients. We talk about Engel here for kind of like, for the sake of simplicity. Of course, this is not epilepsy surgery in itself, so it may not be like technically correct to talk about Engel classification in this case, but what we mean is that those patients that we classified as Engel 1 were free of disabling seizures, either with or without medication, and those with Engel classes 2 or 4 had continuous seizures despite adequate medication, and this was actually a very significant factor decreasing the quality of life in these patients. We also did a multivariate analysis using so-called Tobit regression analysis. Please don't ask me to explain what Tobit regression is. I can't. The epidemiologist experts in our group did this analysis. But anyway, basically what it means that we put factors that had some significance in univariate analysis, entered them into a model and looked what factors turned out to be independently explaining a decrease in 15D score, and these were increasing age. The older you are, the lower quality of life you have, not surprising at all. Female sex did significantly decrease the 15D score in our cohort. Number of bleeding episodes, so that each step was statistically significant. Those with one bleeding episode had significantly lower quality of life than those with unruptured AVMs, and those with multiple bleeding episodes had significantly lower quality of life than those with only one bleeding episode. Again, refractory epilepsy significantly decreased 15D score, and SPECT/PONS class C AVMs had significant lower quality of life than those with either SPECT/PONS A or B AVMs. And doing this, we also evaluated the functional status of the patients using modified Rankin scale at the time when they fulfilled the quality of life survey. And we did one interesting observation that we thought that was worth of publishing by itself. Well, I mean, in the previous section, I didn't talk about modified ranking scale at all. Of course, the higher your MRS score, meaning that more disabled you are, the lower your quality of life is. That's obvious, and that's what we observed. But what's interesting comes next. Here we actually had we didn't exclude patients with untreated AVMs. We used the data from everyone who replied. We excluded only 2 cases in whom the quality of life questionnaire was filled by a relative. There were 2 cases with MRS 5, meaning that they were like a severely disabled in bedridden patients, and those 2 patients we excluded from this analysis. But we divided the patients into sub-cohorts based on their modified ranking score. Most of them were at 0, meaning that they didn't have any obvious remaining disabling symptoms left. And these are the 15D profiles stratified according to MRS grade at the time of survey. And what you can see is that those cases with MRS 0, meaning no disability, have actually excellent quality of life. This is actually better than the general background population, which makes sense because in general background population, in an unselected random sample, you have people in whom the MRS grade would not be 0. But in these cases, the quality of life is actually really, truly excellent. But if you look at the other ones, MRS 1, MRS 2, basically no difference at all. MRS 3, slightly lower than MRS 1 and 2, but still pretty close. And you really have to go to MRS 4 to start to see really robust decreases in the quality of life. If we look at the compare MRS 0 and 1 more closely, you can see that except for 2 sub-items, breathing and eating dimensions, they differ statistically significantly in all other items as well as the total 15D score. These are the dashed line are the 95% confidence interval. And why this is interesting, why this is a little bit of a problem? Well, the problem comes from the fact that we, vascular neurosurgeons, vascular neurologists are bound and very, we like to dichotomize MRS in our research. And the very common cut points are between 1 and 2. Sometimes if it's, let's say, a more dangerous lesion, more dangerous disease, we might put the cut point between 2 and 3. But we like to, combine MRS grades 0 and 1 into one outcome cohort, and these seem to be based on the quality of life that these patients experience. These are completely different groups, and what I mean is that the very simple functional outcome measure like modified ranking score might actually not reflect the quality of life of the patients very well. It's just too crude. Now, unfortunately, I don't have a good solution how we should do this, because statistically, it makes a lot of sense to dichotomize patients with something with some rather simple variable like MRS, but at least we should acknowledge the fact that that MRS in stroke studies may not reflect very well the quality of life of the patients. Well, it does, but the way, but let's say the steps are not even closely equal. MRS 0 is completely in a class of its own. 1, 2, 3 seem to go very closely together. 4 and 5 are then again a completely different story. At least you should keep this in mind. So to conclude, I see that I'm actually kept my time pretty well as planned. So a few take-home messages. The average annual risk of hemorrhage from an untreated AVM is 2 to 3% per year, but remember that the risk is really variable and may vary from less than 1% to over 10% per year, depending on the type of the lesion. And the previous hemorrhage is probably the most robust predictor of future hemorrhage. Also, untreated AVMs are associated with significant increase in long-term mortality. Probably is to some degree true also for those that are diagnosed in unruptured state. AVM patients have decreased health-related quality of life despite complete occlusion, with several factors that decrease the quality of life further, including multiple bleeding episodes, refractory epilepsy, disability as reflected in modified Rankin score, and high-grade AVMs being risk factors for even further reduced quality of life. And also please bear in mind that MRS dichotomization cut points in stroke research may be problematic with regards to the quality of life of the patients. Yeah, I think that's all, folks. Thank you very much.
Okay, thank you very much for this very interesting talk and the many details. And yes, you show the whole experience of the Helsinki group. And there are some questions, and I also have some questions. So let's start with the questions from the chat. There was one, did your quality of life assessments also included data on anxiety of patients with treated versus non-treated AVMs?
Yes, so I mean we had some patients. I mean there were about, we have data in about I think 70 patients with untreated AVMs. We haven't really looked it in that sense that how much the untreated cases differ from the treated ones, because those cohorts are anyway, they are very different. There are multiple reasons why the AVMs might be untreated, and one reason being that those who are untreated were diagnosed decades ago. They are still alive, but on average they are older than our treated cohort, and that will affect the quality of life data quite a lot actually. And I understand the question really well, that you know that the patient being anxious about having something that may cause an acute stroke that hasn't been treated. But also I have to say that the 15D instrument is probably, I mean, it's not designed to analyze that specific question very well. I think that I think this is something that should be studied with a questionnaire that's designed for this type of anxiety to show a meaningful result. But the question is very interesting, and I think that this is something that should be studied not necessarily on AVM patients because they are much more rare, but I think that the unruptured aneurysm cases, which are, you know, tenfold more frequent, would be an excellent patient population for this type of study. Can we really decrease the anxiety of unruptured aneurysm carriers by treating the aneurysm or not? I think it's extremely interesting question. White, you froze, or then I froze.
Sorry, I have problems with my internet. So
okay,
now
you're back online. Okay.
Yeah, that's why I didn't
know if it's you or me.
Okay, but so now it's working again.
Yeah.
And hopefully for the next minutes. There's one question from Dr. Tanaris. He asks, are any patients from the previously published Helsinki series still follow up? So do you continuing with your data collection, Aki?
Yeah, well, yes and no. The thing with the like a kind of like retrospective cohort like ours is that when we did our natural history analysis like 15 years ago, almost 15 years ago, we contacted and collected the data from all those historical patients. I mean, if they have been treated, or even if they have been left untreated, but are, you know, asymptomatic or maybe died of because some other reasons, we don't have tools to actively collect like online data from them. It's just not feasible. And of course, if something happens, and if they still live in, you know, Finland or in southern Finland at least, we would find out. But we are not actively collecting natural history data anymore, because when we did it, it was a huge effort, and to be honest, I don't believe that doing it again from the like as an extension of the same cohort would be worth the effort, because we already had 40 years of follow-up. I don't think adding 10-20 years to that when many of the oldest patients have died for whatever reason anyway would be worth the effort. So actively we are not collecting natural history data anymore. No.
So I have a question, because you have a large cohort of patients which were not treated, and so I asked myself during your talk how your decision making was not to treat the patient, because you have your own experience. You see that the people are bleeding, that you have certain risk factors, or you feel that there are risk factors. How you have been able to collect such a high number of untreated patients over the years? Probably because you started very early with the data collection.
That's the reason. I mean, many of these cases in the natural history cohort, they were diagnosed in the first one was diagnosed in 1942, and then especially the treatment attitude for AVMs was rather conservative until, let's say, late 90s or so. So there was a large cohort that was formed before that, and since they were left untreated during those decades, and if everything went fine, they remained unruptured. Nothing was done. Then again, remember that for the natural history follow-up, that if they experienced a rupture, they probably were treated at that point anyway, because but that patient can still contribute to that natural history follow-up for all that time that went between the diagnosis and something happened. And even ruptured cases may have been left untreated during those old times, which is why we actually have ruptured cases. I mean, it doesn't mean that all AVMs were left untreated in Helsinki for decades. Actually, the first AVM surgeries in Helsinki were done already in 1940s, but those were mainly younger patients and with lesions that were deemed operable at the time with the methods that were available during those times. I don't, and to be honest, I don't think that that the treatment policy was even more conservative in Helsinki than in many other academic centers of that time. The reason why we have this data is probably like the little bit unique healthcare system record keeping and isolated population that doesn't like to move. So because we were able to find, I mean, we only had one university hospital for decades in the last century that, every time that patient had something like this, the patient was sent to Helsinki for diagnosis and evaluation. So we got all the patients from our small population. We kept the records. We were able to find those cases from the patient records decades after, and we were able to find the whereabouts and the fate of the patients retrospectively, even several decades after the diagnosis.
Mm-hmm. Okay.
And of course, I mean, it was a huge effort, but the Nordic record keeping and social isolation made it possible.
Okay. There's a question from Dr. Sinclair. I think it's a difficult question, and it could be a talk on its own. He asks, how has Aruba affected your practice?
Well, we could have another webinar about Aruba and
Absolutely.
But let's say that I think it's obvious that despite all the problems with Aruba, and we might disagree as much as we want about its results, what it has done is that we have to justify better nowadays if we start to treat an unruptured AVM. I don't think it has affected the treatment of ruptured AVMs at all. For unruptured cases, I think we have to justify the decision to treat better than before, which is not necessarily a bad thing at all. And at the same time, not only because of Aruba, but because of, you know, collective global experience and more patient cohorts being published and so forth, we have come to realize that there definitely are AVMs that are probably best left untreated. Unruptured high-grade AVMs, you know, specimen in grades 4 and 5, unruptured, in a middle-aged patients, I don't think anybody in their right mind would want to recommend treatment for that kind of lesion, because probably the patient fares better if you leave it alone. Then if it ruptures, it's a different story, and then maybe you need to do something. But yeah, I mean, I would say that we have become more conservative, not only because of Aruba, but partially because of that, and I think it makes sense and is wise. For a specimen in grade 1 or 2 AVM unruptured in a young patient, I discuss it with the patient, and if the patient and I both feel that it's better to take it out, we treat it. Aruba or no Aruba. It doesn't, in my mind, it doesn't preclude us or it doesn't make the treatment of unruptured AVMs illegal or forbidden but we need to be able to justify what we are doing.
There's one question. I hope I understood the question in the right way. So the question is, if you have an accidentally discovered AVM and you're telling the patient about the diagnosis, do you think diagnosis put an extra stress on the patient and might be a factor for rupture?
I don't. Difficult to say, but I don't. I think I don't know. I mean, I don't think so. I think that the rupture of an AVM is probably still such a complex hemodynamical phenomenon that I don't think. And I mean, if you find something like that in a patient, I think that unfortunately you just you have to tell the patient. I mean, I don't think you cannot not tell the patient about something like this, and I doubt that the psychological stress would cause it to rupture. I think, you know, I mean, unruptured aneurysm is hemodynamically much more simple lesion, and probably the rupture of an aneurysm is probably much more related to things like blood pressure than rupture of an AVM, and we have to tell about those, and I don't think it actually affects the rupture risk itself.
I have another question. Sometimes if you're hearing talks about carcinomas and AVMs and about a higher, let's say, bleeding risk in infratentorial and in deep-seated lesions, I asked myself, it's if they're truly bleeding more or if they're leading more frequently to symptoms and they're diagnosed with a bleeding. What do you think about this?
I understand your question, and this has been asked me many times before, and my pragmatic answer to this is that does it really matter? Because I think we are only interested in symptomatic ruptures. I mean, if the rupture is completely asymptomatic to the patient.
Okay, there's a question. You mentioned the annual rupture risk in the Aruba study of 2.5%. The discussant asked or mentioned that Aruba only looked at unruptured AVMs, where you also included ruptured AVMs. Do you think your study is a bit comparable with the Aruba study concerning the rupture risk?
Yes, it is. Let me share my screen again. I show you the slide that is relevant here. Let's see. Because when I mentioned that, I talked about unruptured cases in our series. Just a second, I need to get to the right slide. Oh boy. This is difficult, too complicated. Here we go. Just a second. Here. Can you see this?
No, not at the moment.
Not in the moment. Okay.
I think you have to share it again.
Yeah, okay. Let's see. Now.
Now it's yes.
Yes. So for the first 5 years, so the Aruba, I mean, this is the original Aruba followed up the patients for 5 years, 2.6% rupture rate per year. If you look at our cohort, first 5 years, unruptured AVMs had a 2.3% rupture rate for the first 5 years after diagnosis. Same thing as Aruba, basically, for the first 5 years. In ruptured AVMs, the rupture risk for the first 5 years was 6.2% per year. So this number, for the first 5 years, this number is almost identical to Aruba. For the ruptured, it's almost 3 times higher. So that was my point.
Okay, let's see. There's 2 questions from Dr. Chan. Do you think that race plays a role in AVM rupture?
I'm definitely not, and I mean, there is data saying that it does. I'm definitely absolutely not an expert on this because Finns are genetically so homogeneous population, like 99% of our cohort were native Finns. So I don't know, but I think that for example, in American studies, the African Americans, I think, had a higher rupture risk than white Americans. I'm not sure if people look, for example, that whether Asian versus European descendant have a different rupture rate, or Asian versus was African. That I don't know. Probably the person who would know best would be Helen Kim from San Francisco, because he's the principal investigator of the Mars effort, which is the global multi-center center study of this. But yeah, so I think it may play a role, but I cannot talk about my own data. And there may also be confounding factors like other health problems, because we know that, for example, in the American cohorts, the African Americans may have different health profile than European descendant Americans or Hispanic or Native Americans.
There's one question also from Dr. Chan. Rupture risk during pregnancy?
That's a difficult and that's a very difficult and very interesting and relevant question, because it's not that rare that gynecologist, for example, consults us about a young female who is known to have an unruptured AVM and is now pregnant. And there's conflicting data about it. And to be honest, I don't know. I don't know the answer because of the conflicting data in the literature. Let's say that this is purely anecdotal, not scientific at all. But I've seen and treated a number of pregnant women with ruptured AVMs and also ruptured aneurysms in my life. And basically all of them have had the bleeding during pregnancy, like mid-pregnancy, not during labor. I think it's extremely rare to have a bleeding during labor. But whether it's just statistical incidence that it happens during pregnancy, because obviously there's no reason to think that pregnancy would prevent the rupture, or whether there's something in pregnancy that increases the risk, I honestly don't know. We've thought about studying this, but it's also extremely difficult thing to study because it's a statistical mess to somehow tease out the period of pregnancy out of the lifespan of the other lifespan of a woman. So very difficult question, but clinically relevant. Just, you know, for the record, if we are consulted about the delivery of a woman with known AVM or an unruptured aneurysm, we just tell the obstetrician that they should decide on the delivery method based on obstetric considerations, and we tell that the unruptured AVM or aneurysm is not a contraindication for vaginal delivery, but very little hard evidence to say anything about this.
A very important advice from a high volume center. So then the last question is coming from me. So you're concerning your quality of life talk. So you took a time point, but do you think it could be, and do you think that the quality of life changes over the years?
Absolutely.
To say it negatively, it could be that if you're looking after 10 years after surgery, you have again a quite normal quality of life. But in the first 10 years up to this point, the quality of life could have been worse than of the normal population, and which also might can result in thinking about, should I do the operation or not? What do you think about this?
Yeah, absolutely. I mean, it's the weakest point in our study is that it's a huge it's a large cohort that spans decades in terms of when the diagnosis was made, when the treatment was given, and my answer to this is that we simply don't know the answer to your question, and it's likely that it's extremely likely that the quality of life doesn't remain constant. The reason we did it the way we did was twofold. The first is that the quality of the objectively measured quality of life is something that we only now have started to measure. We just haven't. Nobody has measured it well in our patients, and we should start at some place. And we started it now from doing it like this way. And the reason we did it this way was that this was the only way to get large enough cohort to get some kind of overall idea. For the future studies, of course, we should measure quality of life more prospectively and with relevant time points related to diagnosis and treatment. And to my big what makes me happy is that the administration of our hospital has realized this as well, and there's now big effort in Helsinki University Hospital that with all this digital stuff that patients can have these can log into their own patient records and input data themselves and so forth so easily, is that there's now a big project that we start to that the hospital starts to collect prospectively 15D measured quality of life in all patients that come to the hospital, regardless of what disease, not only neurosurgical, neurological, all patients. I mean, if you come as a patient to a hospital, at some point you get an invitation and a login link where you can fill out this questionnaire, which is takes only a few minutes, and then you can collect it from several time points over your treatment and over your life. And of course, this doesn't we don't get a lot of data soon, but over years and over the next decades, we really start to get tons of data that has been collected prospectively in relevant time points. So for the future, it will be kind of a gold mine to really start to understand whether we are really helping the patients, whether we are actually improving their quality of life, because I think that's what we should be doing, increasing the quality of life, not making their post-op images nicer, but really improving their lives. White is again having problem with the internet connection, I think.
Okay, you still hear me, or if you can hear me, I would say that this was the last question. And do you hear me?
I can hear you.
Yeah. Okay. So. Okay.
Little bit patchy. Okay.
But I would like to say these are the last words, perfect last words from you. And it was a very nice, interesting webinar. Yeah. And we just close the section.
Okay, thank you, Wade, and thank you, everybody.
Thank you, Aki.
It was a pleasure, and see you around in Belgrade at latest.